morning to one and all. On behalf of Department of Periodontology, Saraswati Dental College, I, Dr. Ruchi Srivastava, welcome you all in this lecture series, Perioshastra 2021. Now, I take the privilege to introduce and welcome our guest speaker of the day, Dr. Vandana Pant ma'am. Dr. Vandana has graduated and post-graduated from King George Medical University, Lucknow. She has more than 18 years of clinical and teaching experience in the field of periodontology and implantology. She has numerous publications in national and international journals of high repute. Her current research is focused to understand the cellular and molecular mechanism involved in the osteogenic differentiation of human stem cells derived from umbilical cord blood from persons' platelet fibrin for their possible applicability in therapeutic intervention of periodontal diseases.
Ashish
Has devoted interest in complete implant rehab and is a fellow of Academy of Oral Implantology. Presently, she is working as a professor and head of Department of Periodontology, Babu Banarsi Das Dental College, Lucknow. I would now like to invite Dr. Vandana ma'am for her presentation on systemic anti-infective therapy for periodontal disease. Over to you, ma'am. Can you share your screen?
Yeah, I
गिफ्ट
can.
नहीं मिलेगा पागल है
योर नेम क्या लिख दो कुछ भी
Is the screen visible?
एम बुलाना लिख दो है ना
Is the screen visible?
You are not audible, ma'am.
क्या करना है बताओ इसमें नाम लिखना है
All the participants, please mute yourselves.
Am I audible now?
Yes, ma'am, you are audible.
Okay. Is my screen visible?
Yes, ma'am, it's visible.
Okay. Just a minute. Yes. First of all, a very good morning to everyone. And I would like to thank Dr. Vivek Bains for providing me this platform for presenting this topic of my interest. This was the topic.
Dr. Vandana, sorry to interrupt you. Kindly slide show karo apna, please. Start a slideshow.
Slideshow. Just a minute. Okay, is this now visible?
Ji, doctor, please.
Oh, okay.
Good morning.
Good morning. Who's there?
Good morning, Dr. Vandana.
Good morning,
good morning, Dr.
sir.
Amitabh. Okay.
Good morning, Ruchi.
Good morning.
Hello, sir.
Hello. Please continue.
Let me minimize this. Can I minimize this? Yes. Everyone please mute. Can other people please mute? Okay. So I just need to adjust few things. Given or anti-infective anti-infective therapy can be given in 3 ways. It can be locally, topically applied, it can be locally delivered, or it can be given systemically. So in this topic, I will be covering only the systemic drugs. And then anti-infective therapy, not in overall, but only those anti-infective therapy which are used for the periodontal diseases. So we will be more precise and we'll try to these are the contents. We will be just giving an introduction, classification of antibiotics, routes and timing of drug administration, antimicrobial dosing principle, duration of antimicrobial therapy, effectiveness of antimicrobial therapy, antimicrobial used in periodontal diseases. So if I start, the antibiotics are the chemical substances produced by microorganisms, which can be fungi, actinomycetes, bacteria, that suppress the growth of or kill other microorganisms. And they are used in very low concentration. This low concentration becomes important because there are many other products, chemical products, which are produced by microorganisms, but they are used in higher quantities like ethanol, like hydrogen peroxide. So they will not be known as antibiotics or anti-infective therapy. This definition becomes important in very low concentration. The purpose of antibiotics is to aid the host defenses in controlling and eliminating microbes that temporarily have overwhelmed the protective host mechanism. Whenever we are infected with so many microorganisms every time, but we don't need those antibiotics because our host system is such that it will combat those. But here, because the host defense mechanism is little bit deteriorated and the microorganism, they supersede. And that is the reason here comes the role of antibiotics. Antibiotics share pharmacokinetic determinant with other drugs, including they have this property of absorption, that is ability to pass through extracellular membranes. Then how they are distributed through the extracellular fluid. Their metabolism is known as biotransformation, and it undergoes by the hepatic enzymes. And finally, they will be excreted either through renal route or the fecal route. This is the route of excretion. Some problem has occurred. The screen is not. I'm not able to. The screen is not shutting. Please excuse me. Actually, the screen is. There is some technical error. Zarana. Actually, the screen is not. Okay, by the time I get my technical expert, we can discuss on these properties. These antibiotics, there are 3 terms. One is antibiotic, one is antimicrobial, and one is chemotherapeutic drugs. So chemotherapeutic, the slide is not moving. The chemotherapeutic drugs are the one. Why was it not moving? क्या हो गया था? मेरे से क्यों नहीं हो रहा था? Okay. Okay. Thank you. Thank you, Dr. Nilesh. Is this screen visible now? Dr. Vivek?
जी
Dr.
डॉक्टर
Ruchi?
जी जी
दिख रहा है? Okay.
कंटिन्यू डॉक्टर.
Yes. These antimicrobial agents, they demonstrate unique pharmacokinetic property, which we are not going to discuss in detail. The volume and distribution of hepatic and renal excretion ratios constitute the major determinant of a drug's half-life. I hope most of you know the half-life. The antimicrobial agent targets a living organism with the physiology different from that of a host by the influence of variables such as microorganism density, growth phase, ease of development of resistance, and glycocalyx formation capable of interfering with antibiotic diffusion. The nature of clinical outcome of antimicrobial therapy depends on these factors, which I hope most of you might be knowing. As I was telling you that there is word chemotherapy. So there are three terminology: antibiotics, chemotherapeutic agents, and antimicrobials. Antibiotic means that the products are produced naturally from the microorganism. The chemotherapeutic word is used because the use of chemical compound in the treatment of infections so as to destroy offending organism or parasite without damaging the host tissue. So these are the only drugs which do not damage the host tissue. There might be certain side effects, but in overall, they do not affect the system of the host. So that is the reason they are also known as chemotherapeutic agent. They are similar to the anti-neoplastic drug. They are also known as chemotherapeutic agent because they also affect the multiplying tissue, actively growing tissue. And they do not affect other host tissue, although they affect up to certain extent. But still they are known as chemotherapeutic agent. It is preferentially the antibiotics they are known as chemotherapeutic agent, and they can be bactericidal or they can be bacteriostatic. Antimicrobial, this term, the antibiotic earlier was known for only of the natural origin, but now so many synthetic and semi-synthetic drugs have come in the role to play. Most of them are interchangeably used. They can be called as antibiotic, even if they are synthetic or semi-synthetic. Otherwise, broadly, we classify under the category of antimicrobial agents. Here, I would like to tell you that I am going to divide my presentation into the three parts. That is how the antimicrobials are going to affect. One thing is major the cell wall synthesis, where the antibiotic affect the cell wall synthesis of the microorganism. Second thing is they affect the protein synthesis of the microorganism. Third is the nucleic acid synthesis that is interfered. All the antibiotic more or less affect in these three ways. If they will affect the cell wall synthesis, they are going to become bactericidal. If they are going to affect the protein synthesis, they will become bacteriostatic. If they affect the nucleic acid synthesis, because that is the genetic material, it is going to be bactericidal again. Although we say that depending on the concentration, these proteins, the antibiotic which affect the protein synthesis of the microorganism, sometimes become bactericidal also, but preferentially they are bacteriostatic. So what are the various drugs? One is the beta-lactam, which affect the cell wall synthesis, under which comes the penicillins and cephalosporins preferentially. Then other drugs are there. Then folate synthesis. This is also bacteriostatic type of drug, sulfonamides and trimethoprim. Sulfonamides and trimethoprim that I will not be discussing in detail, because in periodontal diseases, sulfonamides are not that promising. That is the reason I have omitted this part in my presentation. The nucleic acid synthesis disruption is done by the quinolones and macrolides. Then protein synthesis is affected, protein synthesis affected by macrolides, clindamycin and other drugs, whereas tetracycline and aminoglycoside that affect the 30S subunit of the ribosome, which affect the protein synthesis. So if you memorize these things, you'll be able to understand many aspects of these antimicrobial drugs. If I classify the antibiotic, they have been classified on the basis of chemical structure. So first is the sulfonamides, in which comes the sulfur drugs. Then diaminopyrimidines, trimethoprim, they are very promising drugs in many infections, but they are not much used in periodontal diseases. That is why I have omitted this. Beta-lactam, in which mainly the penicillin and cephalosporins come, tetracycline, in which the doxy and minocycline and tetracycline is there, then nitrobenzene derivative, amino mRNA code that binds to 30S ribosome, where the aminoglycosides are there. Inhibit DNA gyrase and interfere with DNA function. They are the metronidazole and ciprofloxacin. And then again, there are other drugs. Type of organism against which it primarily is active. So it can be antibacterial, antifungal, antiviral, antiprotozoal. So here we are more focused towards the antibacterial, because the periodontal pathogens, mostly they are the bacterial pathogens. And sometimes it is the antifungal, antiviral, but not the antiprotozoal and anti-helminthic. Spectrum of activity, again, this narrow spectrum and broad spectrum is now not much used, although we are conventionally using them, because with the advent of synthetic and semi-synthetic drugs, they are having a broader or extended spectrum. If you are giving a lower concentration or a higher concentration, so these drugs can be overlapped. Narrow spectrum, broad spectrum is now not a preferred term. Type of action, primarily bacteriostatic or bactericidal. So these are the drugs: tetracycline, sulfonamide, azithromycin or erythromycin. These are the drugs which are primarily bacteriostatic, because they are affecting the folate synthesis or the protein synthesis of the microorganism, inhibiting the growth of the microorganism. Whereas penicillin, metronidazole, and ciprofloxacin and cephalosporin, they affect the cell wall synthesis or the nucleic acid synthesis. So that will become bactericidal. Based on the source, most of our drugs are antibiotic of interest. They are of fungal origin, that can be penicillin or cephalosporin. Bacterial origin, these are the one which we are not preferably using: actinomycetes, tetracycline, chloramphenicol, and macrolides. They are of actinomycetes origin. So it is the fungal origin or the actinomycetes origin. This is just an overview so that you can remember. I want you people, while attending this lecture, if you can memorize certain things and retain certain things. Now, beta-lactam, all the dark green colored blocks, they are the bactericidal drugs. Like beta-lactam, where it is affecting the cell wall synthesis, inhibit bacterial cell wall biosynthesis. Aminoglycoside, although we do not deal with this much, inhibit, they are the antitubercular drugs, inhibit the synthesis of protein by bacteria, leading to cell death. Then bactericidal quinolones and yes. And then there are 3 drugs: tetracycline, macrolides, and sulfonamides. These are the drugs which are bactericidal in nature. If we discuss about their application in periodontology, these are the drugs: penicillins, in which comes the amoxi, augmentin, and few more. Tetracycline, preferably doxycycline and tetracycline. Quinolone, it is cipro, ofloxacin. Macrolide, it is erythromycin, we do not use. It is the azithromycin which has shown its promising effects. Then metronidazole, they all are effective in localized aggressive periodontitis, generalized aggressive periodontitis, recurrent, refractory, all those. These are the drugs which are preferred. I'll be discussing this in detail. Now, coming to the route and timing of drug administration. These are the general principles that I will be discussing before going to the drugs being used in periodontology. Route and timing of drug administration are major factors in determining the ultimate concentration at the site of infection. The antibiotic can be administered topically, orally, parenterally, in which it is the IV or IM. With few exceptions, the absorption of antibiotic given orally is decreased in the presence of food because most antibiotics are unstable in acidic media and nearly completely inactivated when the drug is taken just before or after the meal because the gastric secretions are very high. So as a rule of thumb, earlier it was said that the antibiotic should be taken no sooner than 1 hour before or at least 2 hours after a meal. But again, with the advent of semi-synthetic and synthetic drugs, they are not acid labile and they can sustain it and they can be very well absorbed in the presence of food. So we do not prescribe the patient to take the drug before or after the meal. It can be taken simultaneously. In addition, interaction with other orally administered drugs can decrease the external absorption of some antibiotic. Absorption of tetracyclines is decreased in presence of like milk, antacids, and by medications containing ferric salts. They chelate with these material, with the calcium, with the iron, the ferric salt. So they are not used along with them. Then antimicrobial dosing principle, how we dose it, how much has to be given. The proper dose of a drug is the amount of that drug which produces the maximum benefit with minimum adverse effects on the physiology of the host and the microbial ecology. How to decide that? It is first of all, it is the vigorous dosing. High dosage for short duration. The correct drug in antimicrobial therapy is to give a vigorous dosage for a short time as the clinical situation permits. Such a regime is desirable since a major factor in the success of most antimicrobial agent is the height of concentration in the serum and in the infected tissue by a drug. Lesser quantity of the drug for a longer duration is not going to give any benefit. So it is always the maximum permissible dose, not maximum, but which is good for containing the infection, that has to be given and for a shorter duration. High concentrations are more critical in aminoglycosides, metronidazole and quinolone. Prolonged exposure of the organism to antimicrobial agent is more critical, especially in beta-lactam antibiotics. Prolonged dosing beyond what is necessary increases the risk toxicity, allergy, development of resistant microorganisms. It has been perceived that if the antibiotics are given for a longer duration, it might prevent the resistance, it might be good for that, but that is a myth. It has to be given for a particular duration only. And loading dose. For most of the drug, whenever we have an acute infection, we start with a loading dose. Loading dose, if a person is given a loading dose, it will take lesser time to give it maximum effect. But if we are giving without a loading dose, it takes 6 to 12 hours to achieve maximum therapeutic blood and tissue level via oral administration. So for most of the periodontal diseases, we don't need loading dose. But for acute pericoronitis, for aggressive periodontitis, for abscesses, we need that loading dose. Then achieving maximum blood level. Achieve the blood level of antibiotic at 2 to 8 times the minimum inhibitory concentration. Such blood levels are necessary to compensate for the tissue barrier that impede antibiotic penetration to the site of injection. The minimal inhibitory concentration is just in vivo conditions, in lab conditions, and that are effective because there are no barriers. So whenever we are giving to the patient, that has to be increased 2 to 8 times. So minimum inhibitory concentration is decided for the drug to be effective in vivo conditions. Then there should be a frequent dosing interval. With the older beta-lactam antibiotics such as penicillin B and the first generation cephalosporins, so as to maintain relatively constant blood levels. Determine the duration of therapy by remission of disease. The antimicrobial agent is terminated when patient host defenses have gained control of the infection and the infection is reasonably certain to resolve or has resolved. no need to further extend the dose of antibiotics. The body will take care of rest of the things. Improper dosing can be in three forms. It can be inadequate concentration, it can be excessive dosage, it can be inadequate duration of the therapy. Now, duration of antibiotic therapy, for how long we have to give this drug. Conceptual errors about a preordained course of antimicrobial therapy emanate from several faulty assumptions. One is resistant microorganism, that if we give a prolonged antimicrobial therapy, it is going to prevent the resistance of the microorganism. It is not so. For the rebound infection also, if we feel that rebound prolonged antibiotic therapy has to be given, again, that is a misconcept. The variability in infectious process, antibiotic dosages and duration of therapy can be extrapolated from one infection to another. Relapses and remission of infection. The ideal duration of antibiotic therapy is the shortest that will prevent both clinical and microbiological relapse. Remember that for acute orofacial infections that have a rapid onset and relatively short duration, 2 to 6 days or less, particularly if the offending cause is treated or eliminated, like in cases of tooth extraction. If there is acute pulpitis, you have extracted the tooth. If there is abscess, you have drained the abscess. We don't prescribe the drug for more than 3 days. It can be only 2 days also, and that will take care of it. But if it is a contained infection, if it is the subgingival microorganism which is present there, we have not treated it, we will have to prolong it for 5 days to 7 days. When clinical evidence indicates that the infection is reasonably certain to resolve or is resolved, the antibiotic therapy is terminated. And the rule of thumb is that antibiotic coverage should last for at least 48 hours after complete remission of clinical symptoms. For you to understand when to stop the antibiotic, because there is no mathematic calculation or rule for it. So it is the clinician's judgment that how you are going to decide that how much antibiotic has to be given. Treatment of usual oral infections of bacterial origin requires an average of 5 to 7 days of antibiotic therapy if we are not doing any definitive treatment. Definitive treatment means we are not draining the abscess, we have not done the flap surgery. If we have done the flap surgery, well irrigated, everything done, we don't need to prescribe any antibiotic. Although there is a lot of controversy regarding this, whether to give or not to give. So it is always to be on the safer side, we prescribe the antibiotics. But it can be good if you prescribe it for 3 days or maximum 1 day. Effectiveness of antibiotic therapy depends on the age, type, and extent of infection. The time duration of presence of an infection plays an important role in determining the effectiveness of antibiotic therapy. More chronic infections are less susceptible to antibiotic than acute ones. We think that acute one might be requiring more of the chemotherapeutic drug, but it is not so. The one which rapidly occurs will rapidly go also, but one which has taken more time will also take more time to go. So chronic, they are chronic actually. Larger extent of infection, less effective antibiotic therapy owing to big amount of microbial population to deal with. Somebody please mute. Antibiotics by themselves can't be relied to eradicate. Remember this thing. They can't be relied to eradicate some infections. Appreciable quantities of pus, necrotic tissue, and a foreign body, abscessed area that are relatively avascular require prompt surgical management in addition to the adequate dosage of antibiotic. So antibiotic will not remain the treatment completely. We have to do both the things simultaneously. This is the slide of resistance that I'm not going to discuss, how the resistance develop. Then patient compliance is also very important when you are prescribing an antibiotic. Since patient may miss doses when clinical symptoms begin to subside, and a patient may choose to discontinue therapy as soon as overt symptoms are absent. Premature termination of drug therapy will favor the selection of microorganisms that are more resistant to the drug. particularly with the bacteriostatic agents. Patient compliance is a requisite for a successful clinical outcome. Concentration of antibiotics. To be effective, the antibiotic must reach the site of infection in amount above the minimal inventory concentration for pathogen. Metabolism and excretion of antibiotic, alteration of the drug in the living organism is called as biotransformation. The time during which an antibiotic is present in effective concentration at the site of infection depends on the rate of inactivation of the drug through metabolism or excretion or both. There are certain drugs which are metabolized in the liver. It is the hepatic metabolism, or sometimes it is the kidney, which is certain part is metabolized. And then finally, either it will be excreted through the fecal or the renal route. So it depends which drug is being metabolized through which route. If it is metabolized through hepatic route, it will be taking more of the time. So presence will be more. So that is the way the half-life of the drug is decided. Based on this, the dose is repeated at specific intervals so the antibacterial blood concentration is maintained. After absorption, the drug can undergo three possible fates. That is the metabolic degradation, spontaneous change, excretion, as same or unchanged. Beta lactams, again remember this, beta lactams, बाकी हमें नहीं याद करना है, that are excreted mainly through kidney. Rest of all the antibiotics, they undergo varying degree of biotransformation in liver mostly. So whenever patient is suffering from some renal problem, these drugs should not be prescribed to the patient. And if they are having some hepatic problem, these drugs, other drugs cannot be prescribed. Then it will be vice versa. In this hepatic problem, beta lactams can be prescribed, and if it is a renal problem, all other antibiotics can be prescribed. This is the simpler way to learn it. Now coming to drugs one by one. So I will be discussing on the basis of mechanism of the drug. Inhibition of protein synthesis. Inhibition of protein synthesis. In this comes mainly the two drugs will come. One is the tetracycline and second will be the macrolides. The tetracycline, okay, let's skip the chemical part of this. Yes. Group 1, Group 2 and Group 3. Group 1 was tetracycline, which is very rarely now used. And Group 3 is the one which we are commonly using, in which comes the doxycycline and minocycline. So the sources are synthetic and semi-synthetic. Potency of tetracycline was very low, but the potency of these drugs are very high. Intestinal absorption is complete with doxycycline. No interference by food. That is the reason lesser dose is also effective. And plasma protein binding is high. They are eliminated through feces, doxy through feces, and minocycline through urine and bile. Again, this is the reason why the doxycycline has the higher T half-life. The half-life is very long, so that can be given OD once daily. And since this has a lesser, there is a rapid renal excretion, there is very low plasma binding concentration, so that has to be given in a higher doses for 4 times a day. This is given 200 milligram initially, that is the loading dose, and then they can be given 100 or 200 depending on the type of infection once daily. It inhibits protein synthesis by binding 30S ribosome in susceptible organism. It is effective against variety of gram-negative and positive bacteria. It is mainly given orally, secreted in saliva, concentrated in liver, and excreted in bile. They can cross placental barrier. They are used in dentistry in number of conditions. They can also be used as a prophylactic treatment to infective endocarditis. There are different types of infective endocarditis. So tetracyclines can be given. What we remember is the amoxicillin, but there can also be given. But since they have their own side effects, we don't prefer tetracyclines. They are an adjunct to conventional periodontal therapy. They can be used as a treatment for anal and dental abscesses. Dosages is mainly 250 For tetracycline, it is 250 to 500 milligram 4 times a day. The rest of the drug can be given twice daily or once daily. It can be a loading dose of 200 milligram followed by 100 milligram on the subsequent days. So adverse drug reactions. Remember, for most of the antibiotic, the GI disturbance is there. So anorexia and vomiting, they go together. If a person is having vomiting or nausea, anorexia will always be there. Heartburn, diarrhea is also a common symptom for most of the antimicrobials. Epigastric pain, gastroenteritis. Hepatic and renal toxicity can occur. Mainly, this is the reason why we do not prefer the tetracyclines. Tooth coloration, hyperplasia and brown discoloration of teeth can occur. Hence, it should be given in third trimester. It shouldn't be given in third trimester, or preferably it shouldn't be given at all. Earlier, the much antibiotics were not discovered, which could have been given orally. So tetracycline were given, and those side effects were not evident by that time. So those drugs were given in the earlier 19th or 20th century, but later on they were discontinued. In pregnancy and in infants or children under 8 years of age, since it can permanently discolor the developing teeth and can alter bone growth. So this is the discoloration visible on the tooth. Don't confuse it with fluorosis. It is the tetracycline staining. Super infection is a common problem with most of the antibiotic, be it amoxicillin, tetracycline, but for with tetracycline, all the broad spectrum antibiotic will show more of the super infections. Increases blood urea level, and minocycline and doxycycline, they can cause dizziness, vertigo, tinnitus with high dosage. Other adverse effects, though rare, include nephrotoxicity, mild leukopenia, neurotoxicity. You should know about it, as up to some extent it is photosensitive also. The doxycycline is photosensitive as well. When we are prescribing drugs like quinolone group preferentially, they are very photosensitive. These drugs should be taken at night, because patients, when they come into sunlight, they feel some problem with their skin. The contraindication, as I told you, the pregnancy is a contraindication because it can cross the placental barrier and form a stable calcium complex in bone forming tissue, which can result into decrease in the fibula bone growth and retard the skeletal growth. Tetracycline should not be given to nursing mother, as they are excreted in breast milk also. Absorption, fate, and excretion, they are not destroyed by gastric juices or intestinal flora. So they can be given when the food has been taken, but they form an insoluble complex by chelation with calcium, magnesium, aluminum, and hence substances like milk, which contain all these products, all these content should not be used. Ferric and ferrous, they also reduce. So if somebody is taking iron supplement, preferably pregnant ladies or person with anemia, they are taking some iron supplement, so these drugs cannot be prescribed. Food also interferes with bioavailability of the drug. Tetracycline are mainly absorbed from duodenum and upper ileum. They are metabolized in liver, and metabolized are excreted in urine by glomerular filtration. It is bacteriostatic. It has got anti-inflammatory property in or host modulating agent in lower concentration, which is known as host modulation therapy, under which the tetracycline or the doxycycline has been used with 20 milligram concentration. That that part has not been covered at all, because I am not dealing with the host modulation. So these are the properties. And drug interaction. Drug interaction, whenever we are prescribing any drug, we should know with what drugs they are interacting. So oral contraceptives, with the oral contraceptive tetracycline and amoxicillin, they reduce the dosage or efficacy of the contraceptive. So sometimes we ask the patient to take other means also for the contraception. Antacids, again, they have those the compound, the zinc, aluminum, and all those things. So antacids, they should not be used with antacids. This is penicillin. They should not be used with this drug. Any bacteriostatic drug should not be used with the bactericidal drugs. So penicillin and tetracycline cannot be given together. And anticoagulant therapy. Again, this is also very important aspect because nowadays many patients, they are on anticoagulant therapy. They are having one or other type of cardiovascular problem. Because they depress the plasma prothrombin activity, patient on anticoagulant therapy may require decreasing the doses of anticoagulant. Otherwise, patient may suffer from excessive bleeding. So it is with tetracycline, it is with ciprofloxacin and fumarate. Now coming to the macrolides. Macrolides are the group of antibiotics that I am discussing the drugs which will be used mainly in periodontal therapy. That is the reason I am taking the pharmacology of these drugs as well. Pharmacology as well for these drugs. The macrolides are the group of antibiotics that have in common macrocyclic lactone ring linked with amino sugars. Most commonly used members are erythromycin, clindamycin. This has also been used very frequently in infectious diseases, but not used nowadays much because of their own side effects. And azithromycin. This is a novel antibiotic, and we will be discussing more about this in this presentation. Erythromycin, it is bacteriostatic because it interferes with protein synthesis by inhibiting enzyme transferase at 50S subunit of ribosome. Tetracycline were affecting at the 30S subunit of ribosome of the microorganism. And this drug is also effective against the penicillin-resistant staphylococci. Excretion is through urine, bile, and feces. Used in dentistry, again, that can be used for as a prophylactic drug in subacute bacterial endocarditis, or where the patient is allergic to penicillin. Adverse drug reaction, again, it has stomatitis, nausea, jaundice, urticaria, abdominal pain, vomiting, diarrhea, common things. Anaphylaxis can occur with any of the antibiotics. Severe drug reactions are little bit less common. Hepatic dysfunction are contraindication to erythromycin. Superinfection by candida can always develop. Dosage, it is 250 to 500 milligram twice daily. Spectrum, effective against a wide range of gram-positive, facultative, and anaerobic bacteria like Streptococcus, Staphylococcus, Eubacterium, Lactobacillus, Streptococcus species. However, most of the gram-negative species are resistant to erythromycin. This is the reason due to its inability to penetrate the LPS cell wall complex, and this is the reason they are not used in periodontal disease treatments. If we come to absorption and rate and excretion, partially destroyed by gastric juice, and therefore it is necessary to administer it in the ester form. Because this is not going, we are not going to use it so commonly, I am going to skip this slide. Coming to the azithromycin. Azithromycin is also known as more than an antibiotic because again, that has a property where they have the enhanced activity against gram-negative pathogens compared with its predecessor, and is therefore used to treat a wide range of infection, upper respiratory tract infection, middle ear infections, sexually transmitted diseases, trachoma, and also effective ring. This extra N atom provides a higher degree of structural stability, resulting in excellent tissue penetration, low toxicity, and long T plasma half-life of approximately 68 hours. It suppresses periopathogens. It is anti-inflammatory, post-modulatory effect, and long-term healing effect. So these are their property. Uptake of azithromycin, if we compare it by the polymorphonuclear cells and macrophages, it is 10 times higher than that of erythromycin, 26 times higher in macrophages as compared to erythromycin, and only 19% of azithromycin released from cell within the first hour. whereas erythromycin released from cells within first hour is 85%. So you can see the efficacy, the longevity, and the retentivity, substantivity. Uptake by the fibroblast after 72 hours, it is 21 times as compared to erythromycin. Hence, fibroblast may act as a reservoir for the sustained release of azithromycin and the transfer of azithromycin to PMNs migrating through inflamed tissue. This is the reason they have those property of antibacterial effect and the anti-host modulatory effect, and they have a better healing property. So these are the three property of the azithromycin, and the only problem with us is that, especially I have felt that no MR with azithromycin is coming to our department telling us that these are the drugs available, and we are still continuing with only the amoxicillin. But azithromycin, they can be tested, tried, studies can be done to see their efficacy. Now coming to the inhibition of cell wall synthesis. We are left with only 10 minutes. I have to compile within 10 minutes. So I'll be only discussing about the salient points. Cell wall synthesis, it is the penicillins. These are the drug classification of penicillin on the basis of source, route of administration, spectrum of activity, resistance to enzyme, resistance to acids. Which are naturally available is the penicillin G and V, and rest all are the semi-synthetic drugs. If we talk about the administration, so orally MP, amoxy, penicillin V, oxacillin, fluoxacillin, they can be given orally. Parenterally, penicillin G, methicillin, and carbonicillin, they are the important ones. Spectrum of activity, broad spectrum amoxicillin, they are given resistance to enzyme. By this, we can understand, these are the two things by which we can understand why they are given either orally or parenterally. If they are acid stable, they can be given orally. Like penicillin V, ampicillin, amoxy, cloxa, you can see they are the same, which can be given because they are acid labile. If they are acid unstable, they have to be given parenterally. Resistance to beta lactamase, methicillin, cloxacillin. You must not have heard much of the fluoxacillin, the drug with combination of amoxicillin and fluoxacillin were earlier given. Considering that the patient might be having that beta lactamase, the resistance against these antibiotic might be there. So that combination was given, but now that has been withdrawn, that is not no more used. And resistance to beta lactamase, non-resistant to beta lactamase, these are the drugs, so they can be given very easily. Level are twice as high as those after similar dose of ampicillin, absorption not affected by food, and preferentially it is given 250 milligram or 500 milligram. It can be given orally, and any drug can be given IV or IM. That all drugs can be, most of the drugs can be given. So adverse effect, most of the antibiotic can show hypersensitivity, anaphylaxis. IV administration can always be more severe. Fluoxacillin, as I told you, that it is a penicillin resistant penicillin. This drug has weaker antibacterial activity than penicillin G, and it is used in conjunction with the ampicillin and amoxicillin to enhance synergism. So this was about the amoxicillin. Ampicillin are now not that used, so I am skipping that slide. It should always be remembered that an allergy to one penicillin exposes the patient to a greater risk of reaction if another penicillin or cephalosporin is given. Superinfection can also occur as penicillins can alter the normal flora of oral cavity and GI, causing pseudomembranous colitis, fungal infections, etc. In the time of COVID, this has happened that patients were given so many antibiotics without any rationale that those patients were later on infected with superinfections, mucormycosis, and many more problems which are still not reported.
जी डॉक्टर साहब। हेलो हेलो।
5-6 minutes.
Yeah.
Okay. No, I am talking about extending after 10. Or you have some
Actually, ma'am,
you have
we
some
have-
more assignment. Okay, fine.
मैम करिए
Okay.
करिए मैम, कोई बात नहीं डॉक्टर जी, कोई
Okay,
बात
no.
नहीं।
I'll bind it up. So
नहीं,
for
नहीं।
beta lactamase, this is for the students that this is the drug augmentin, which is given in combination with amoxicillin and clavulanate. This enhances the durability, this clavulanate. That is the reason that you can give this drug for twice. Otherwise, amoxicillin has to be given thrice daily. So this enhances, and when we prescribe to the patient either augmentin or mox, clav or any drug, you should know that every time the amoxicillin concentration will be either 250 milligram or 500 milligram, and clavulanate will always be 125 milligram. So when you are prescribing, you will have to write augmentin 625 milligram, because 500 amoxicillin and 125 of clavulanate, 625. Otherwise, it will be 375 if it is 250 milligram. Then coming to cephalosporin. Cephalosporin are also very promising drug, and they are very efficacious because they have the lesser resistance to these beta lactamases. The resistance is not that up to that extent. And can cross the meningitis. That is the reason they are given in those conditions where the meningeal infection is there, and other properties. So these are the drugs you must have heard of. Cephalexin odor surgeons, they prefer these drugs for the contained infections, which are contained, not exposed in the oral cavity. These are the common side effects. Now coming to the interference with nucleic acid. So one part was interference with the protein synthesis, then came the cell wall synthesis interference, and now this is the nucleic acid synthesis, in which there are two drugs, nitroimidazoles and quinolones. They inhibit either DNA and RNA synthesis, and most of them do not exhibit selective toxicity. In the nitroimidazole group comes the metronidazole, tinidazole, and onidazole. And they are very frequently given in other infections as well as the periodontal infections. Metronidazole is used effectively in treatment of pericoronitis, periodontitis, dental and periodontal abscesses. They are very good when combined with amoxicillin or augmentin. It is also used in the treatment of Actinobacillus actinomycetum comitans associated with aggressive periodontitis. Absorption and fate of excretion almost completely absorbed from small intestine. That is why it can be given very easily orally. Very little reaches to colon. Food doesn't affect its bioavailability. It is metabolized in liver mainly and excreted in urine, imparting red-brown color to urine. The drug passes from placental barrier and is present in milk. The drug adverse reactions are mostly the same. It is the metallic taste in the mouth with metronidazole. With alcohol, it can give a disulfiram-like reaction. So it should not be given with the alcoholics, or you can ask the patient not to consume alcohol if metronidazoles are given. Again, as I told you, for the anti-tetracycline, this also has that anticoagulant property. It interacts with those drugs, so risk of bleeding increases. So you have to be careful. Many patients are on barbiturates. They decrease the metronidazole level. So if you give, if you don't, you miss, it will not make much effect. But this is going to definitely affect. Disulfiram, this is going to affect the patient and you will feel sorry for that. Metronidazole, this is given 200 or 400 milligram thrice daily or sometimes twice daily. Tinidazole and onidazole, they are given because they have got the higher T half-life, they are given twice daily. If I come to quinolones, they are the group of 1,8-naphthalene. Let's leave this. They are the only drugs which are not of the natural origin. They all are the synthetic origin drug. That is the reason you can call them not a true antibiotic, but now antibiotic cover everything, whatever is. That is the reason the title of my topic was anti-infective therapy. Then ciprofloxacin is the second generation drug. Mechanism of action, it affects the DNA gyrase, and these are the second generation drug which are of concern, which we are more good antimicrobial property and excellent activity against wide range of gram-negative microorganism, good activity against gram-positive bacteria. They are the only one which are active against all strains of AA. It does not cross-react with any other. This is the best part of ciprofloxacin. And in fact, some additive effect will be seen if given with beta-lactam, aminoglycoside, lindametro. Bactericidal drug should be given with bactericidal only and static with static for the synergism. Those two cannot go together. Adverse effect, nausea, vomiting, photosensitivity, and all others are seen. They are excreted in breast milk, may cross the placental barrier. Therefore, it should not be given to pregnant and nursing females, except in cases of severe infection. Quinolones are not recommended for prepubertal children, but again, ofloxacin in cases of typhoid, if the child is suffering from typhoid, this ofloxacin is given in 200 milligram or 100 milligram dosage. Then drug resistance, this also should not be given with antacids containing magnesium, aluminum, calcium, and zinc. Dosages is 250 to 500 milligram twice daily. Ofloxacin, it is 200 to 400 milligram once daily or sometime twice daily. And I had thought that we will be summarizing it and discussing it with all of you one by one, but I'm going to skip this. Yes, again, you can have a look of this. Metronidazole, 90% absorption for oral administration. Amoxicillin, 75%, tetracycline, 93%. You can understand that how effective they are. If they are maximum absorbed, they are going to be more efficacious. Then peak serum level, this is the deciding factor for the dosage. Serum half-life, duration, this will determine, and common side effect, diarrhea, nausea, vomiting, hypersensitivity, photosensitivity. With the tetracycline and with the fluoroquinolones, photosensitivity, you can see. Yes, these are the two drugs which show the photosensitivity. Dosage, metro is 250 or 500 milligram. If 250, 3 times, twice daily. Amoxi dosage is this, and azithromycin again 250 to 500 milligram, but once daily. Fluoroquinolones 500 milligram twice daily. So this is the dosage. In pregnancy, what are the drugs that are probably safe? So metronidazole should be avoided. Penicillin is probably safe. Tetracycline contraindicated. Erythromycin avoided. Fluoroquinolones contraindicated. In children, promising result, but due to their own side effects, we do not prefer them, but they are very good as an anti-infective therapy. Amoxi plus clavulanic acid, azithromycin, metroamoxi, and spiramycin. In aggressive periodontitis, tetracycline, because They are also available in the GCF, metronidazole, because they are also present in higher concentration in the GCF for the longer activity. So they are preferred for the aggressive periodontitis treatment. Also clavulin, amoxicillin plus clavulinic acid plus metronidazole, they can be given. And again, dosage will remain the same. Necrotizing ulcerative periodontal diseases or necrotizing periodontal diseases, it is amoxi, metro, or combination. These drugs are effective. Periodontal abscess, it is amoxicillin, loading dose 1 gram, followed by 500 milligram. If person is allergic to beta-lactam, then clindamycin can be given. Combination and serial therapy, as I told you, they give the synergism to the effect. But bactericidal should be given with bactericidal, not the combination of the two. Stridal and static cannot be given. The disadvantages of the combination can be increased adverse reaction, antagonist drug interaction if improperly selected antibiotic are given, a bactericidal antibiotic and combination. They are given as a prophylactic treatment in compromised patient with acute infective endocarditis. We give the prophylactic drug. We give prophylactic drugs for many other cases where we feel that after our treatment, we are going to increase the microbial load in the blood. Earlier, it was 3 grams of amoxicillin 1 hour prior to our treatment of amoxicillin, but now the American Association of Cardiothoracic Surgeons, they have now come to a conclusion that 1 gram of amoxicillin 1 hour prior to periodontal procedure is efficacious. We don't have to give 3 milligram. It is 1, 2, 3, whatever person feels. The benefit of prophylaxis must outweigh the risk of taking the antibiotic. The antibiotic must be present in the blood and target tissue prior to dissemination of the organism into the blood. An antibiotic loading dose must be used. The choice of antibiotic must be made on the basis of single most likely microorganism to cause the infection, and financial aspect has to be seen. There are various medical harm. Now coming to the conclusion. So systemic periodontal antibiotic therapy aims to reinforce mechanical periodontal treatment and to support the host defense system. In overcoming the infection by killing subgingival pathogens that remain after conventional mechanical periodontal therapy. Single antimicrobial drug therapies are able to suppress the number of subgingival indigenous bacteria for a prolonged period of time, depending on the host defense and oral hygiene efforts. Combination drug therapies aim at enlarging the antimicrobial spectrum and exploiting synergy between antibiotics and may be indicated with complex mixed subgingival infections. So these are the references I have read and taken from KD Tripathi, Clinical Periodontology, Karanza, and the Perio 2000. Many part of this has been taken from Perio 2000. You can see those things. And thank you all. I wanted to have a interactive session with all of you, but I think the time may not permit. Dr. Vivek, do you have to say anything?
I will thank you, Doctor. Just wait for a minute. Dr. Ruchi, please carry on.
Thank you, ma'am, for such an elaborate deliberation. Now I invite Dr. Vivek Bain, sir, HOD Department of Periodontology, Saraswati Dental College, for a few words of appreciation. Over to you, sir.
Thank you, Dr. Vanna, for the wonderful deliberation. And this is certificate of appreciation for you. I would like to thank you for the insight you have given, and wonderfully you actually compiled the lecture, specifically that about the azithromycin, and at last you were telling about the interaction, about various drugs. So it was really very good insight, and it will be helpful for the student. And I would like to thank all many faculty members have also joined. Dr. Amitabh was there from Sardar Patel, Dr. Sanjay Gupta from Career Dental College, then Dr. Surinder, Dr. Shalu, Dr. Varsha was there from Mumbai, and Dr. Sanjeev Salaria from Meerut, Dr. Balaji from Bhubaneswar, Dr. Gurpreet from Derabasi, And I'm thankful to everyone. Thanks to all the postgraduates for giving the time. Next Thursday, we have Deepavali. And after that, on 11th of November, we have lecture by Dr. Shipra Gupta from PGI Chandigarh. So thank you very much for the participation. Dr. Ruchi?
Thank you once again for all the participants for joining this Perioshastra. Hope you all had a great learning experience. Thank you one and all.
So we can exit.
हाँ जी डॉक्टर साहब बिल्कुल.
Okay, even
Actually,
I
there was no
aware.
question actually. So I guess everyone is wise, so we don't require any interaction from that also. Thank you, Dr.
Convey my regards to all the faculty members who were there present. I was not able to identify them. Especially, I can now see Dr. Bala, Amitabh Srivastava, Dr. Mona is there.
Yeah, Dr. Mona is also
Sanjay
there.
Gupta.
Sorry, I missed the
Yeah.
name also.
Okay.
And thank you, Dr. Saab. Thank you very much.
Okay. Have a good day. Bye.
Thank you.
Bye.
Thank you.